I would like to call upon the dais Dr. Shilpa Satarkar ma'am to present on fetal abdomen anatomy.
Good afternoon, everyone. I'll take the opportunity to thank my own Aurangabad team for giving me the opportunity in this Marathwada Con. So basically, Mr. Beginning with, it was decided that there will be only adult anatomy and everything, but I forced the organizers that it should be from womb to tomb, so then we decided to have fetus also in this. So let's go to the normal anatomy of the fetal abdomen and the pelvis. When we say anything about anatomy, basically there are two concepts. That is a sectional anatomy, that means multiple organs are visualized in one section, and we should know the relations of this. We should know the relations of the various organs in that section. And then second is the system anatomy, in which we should know that each organ of the system can be visualized in different planes, and it will be looking different in the different planes. So that we need to understand. And for any fetal examination, the beginning is with the evaluation of the situs. There are multiple methods, but the best is to imagine yourself in the fetal position. And if you are not able to do that, you can keep a teddy with you, with a neutral gender teddy, so that the PNDT people will not trap you. So first we should go with the situs, and on the situs basically we have to understand the normal situs landmarks, the abdominal situs and the cardiac situs we should know. Always the liver is on the right, the stomach is on the left, and then the spleen and these small organs which are very difficult to see on ultrasound, we don't take in the situs evaluation, but yes, in abnormal cases we have to take that. And then the major things like the aorta is on the left and the IVC is on the right and the anterior. And the cardiac situs I won't go in detail because tomorrow it will be again covered. And then in the abdomen and the pelvis, we evaluate the abdomen and pelvis in the three planes basically. So there are three axial planes. So one plane which passes through our abdominal section, where we look at the liver and then the stomach. The second section passes through the area where the umbilical cord inserts, and that area we need to evaluate in the black and white as well as on the color exactly, because we have to see the location of this area. And then the third section passes obliquely to the pelvis, where we are going to evaluate the umbilical arteries, and then we are going to evaluate the bladder. The visualization of the bladder is very much important, and in this section we can also look for the kidneys also. The second section are the two coronal planes. The first coronal plane, it goes slightly like posterior, where we can see the diaphragms very well. We have to differentiate the stomach and the diaphragm, and the diaphragmatic line we need to differentiate. Here you can see the hypoechoic liver, the hyperechoic lung. This differentiation makes the diaphragm very clear. And then a slightly coronal section which goes still posteriorly, where you can see both the renal arteries, both the kidneys, and then also if you want you can go for the Doppler evaluation, where the renal artery conformation will definitely give you a lot of confidence that yes, the kidneys are present there. And the third section is the parasag and the parietal section. It can be in the prone position or it can be in the supine position. Again here the most important thing which we are going to look are the diaphragm and the kidneys, but still about that, what we are going to concentrate here is more on the anterior abdominal wall. The anterior abdominal wall evaluation is very important. In the first trimester itself, there should be no anterior abdominal abnormality which should go in the second trimester for diagnosis. So that we have to evaluate in the parasag and the parietal sections. And then we have to also evaluate the vascular anatomy in the first trimester. So in the first trimester, we all take the ductus venosus. We know how to evaluate the ductus venosus. It is the continuation of the umbilical vein. And then we identify that with the aliasing, and then we take the waveform. So in the first trimester, we always take the ductus venosus in the parietal plane. Why we take it in the parietal plane? So basically, if you see in this diagram, the ductus venosus is an oblique vessel, and that oblique vessel of 0.7 to 0.8 millimeters, to visualize that in the axial section becomes very difficult, and therefore in the first trimester, it is always on a coronal, always on the parietal section where we take the ductus venosus. And then in the second trimester, this IUCOG basic guidelines, they have given some 20 planes which help us to evaluate around 50 abnormal patterns in the fetus. So of that, the 11, 12, 13 and 14 are related to the abdomen and the pelvis. It are the same plane almost of the first trimester, but here you can see that in we can see the vascular anatomy quite properly in the second trimester. So this is our AC section plane where we see the stomach, and here we see the umbilical artery and the portal sinus. This J of this, the concavity, should always face opposite to the stomach. And then the second plane is that of the cord insertion, where we have to see cord insertion is there and the abdominal wall is intact and nothing should go along with the cord here. The third plane, the plane 13, is at the level of the kidney, the axial section, where we take the measurements of the renal pelvic diameter. We by taking this measurement, we make sure that yes, we are visualizing both the kidneys. This RPD can be taken at spine 6 o'clock or spine 12 o'clock position. Both are okay with that. And then the plane, the next plane, the plane number 14, is for the pelvis and the umbilical vessels, where visualization of the bladder is must in every scan. If you don't visualize bladder in this 3 vessel cord view, again review for that. So for that, what they have recommended, that when we start our examination, any fetal examination, we have to look at the two major dynamic structures of stomach and the urinary bladder at the beginning itself. Once you see that and take the images of that, then it's okay. If you start visualizing them at the last, and if you don't see these structures, again you have to wait till the structures are filled. And therefore we need to start them visualizing early itself. So now look at this case here. But we have to look bladder in each and every of our case. Now look here, this case. So I don't know why. Okay, here you can see that the 3 vessel cord is seen very properly and it was reported to be normal. And when the patient came in the second trimester, you can see that it was a persistently non-visualized bladder. And here you can see just above this, just below this cord insertion, you can see this slightly elevated area here. And it was a case of bladder extrophy basically. So this was bladder extrophy, which because the bladder was not visualized and just the 3 vessel we were visualized in the first trimester, it got missed. So we have to look urinary bladder in each and every case. Now after this sectional anatomy, let's come to the system anatomy, where we'll be evaluating the GIT, the anterior-abdominal wall, GUT, and basically the new kid in the thing. That is the vascular anatomy of the abdomen, which is very important and which is going to point us to various abnormalities. So basically for the GI hollow organs with peristalsis, we have to remember few things, few very basic and important things, and which we need to tell to the patient also in our counseling. And they are basically that the appearance changed throughout the pregnancy. The appearance will change during the scan also. Many signs of the anomaly can be seen in the 3rd trimester, like the bowel atrasias, and there can be no sonographic sign during whole of the pregnancy in spite of the patient having some anomaly. The commonest which we encounter are the esophageal atrasias with TO fistula. All these things we need to be aware, and also these things we need to be aware during our counseling also. Then as we know that stomach can be seen as early as 7 to 8 weeks of gestation and must be seen by 12 in all. It should be at the left quadrant of the abdomen, and then there are significant wide ranges in the shape depending on how much is swallowed. So it can be from oval to kidney shaped or round shaped, any shape. The size can range from 4 millimeter to 4 centimeter basically. And what things we are going to see when we see the stomach, if it is present or there, if it absent, what is the size of the stomach, and if it's a dilated stomach. Position of stomach identifications become very easy. If you don't see the stomach in the abdomen, you look at the thorax, and then you can very well see that the stomach is in the upper abdomen. But the problem comes when there is a very small stomach or there is a very big stomach. What are we going to do? So whenever we see that there is a very small stomach, we are going to ask the patient to wait for some few half hour, 2 hours. Maybe again you evaluate. If it is filled, well and good. If it is not filled, again 4-6 hours you evaluate. Again call the patient next day. And in spite of that, if you are not visualizing, again call the patient after 2 weeks. This is the protocol for absent stomach and a small stomach. And once you don't see, in spite of that, the stomach size is small, then you have to write in your report that yes, in spite of so and so evaluation, after so and so period, the stomach is still small and it could be associated with some abnormality. Similarly, with dilated stomach also, we have to follow the same protocol, but with dilated stomach, we have to look that yes, if there is any associated polyhydramnios or not. And these are the causes of the absent stomach. And then also in counseling, this part should be very important, that the presence of stomach will not rule out the esophageal atrasias. Then there are some echoes in the stomach called as gastric pseudomasses, which are transient thing. And whenever we see such type of pseudomasses, we have to see if there is any placental abruption, If a placenta abrasion is there, then because of swallowing of blood, these features can be there. With amnio also, with blood in the amniotic fluid, we may get some echoes in the bladder. And secondly, if dilated loops are there, yes, we get this type of gastric pseudomasses, which are nothing but some swallowed material in the amniotic fluid. Duodenum we normally don't visualize in our routine scan, but duodenum is best seen between 19 to 23 weeks of gestation. The duodenal bulb, to begin with, it is a linear line, and then at 30 weeks it can be seen as a duodenal bulb, can be seen as a triangle, and in third trimester it becomes very prominent. And when we say that it is a double duodenal, double bubble sign in the duodenum, the most important thing we have to demonstrate is the connection between these two bulbs. Unless you demonstrate the connection and the gut sign which can be seen on a very high frequency probe, where we see the very three prominent layers, that gut sign you have to demonstrate, and then we have to demonstrate the connection. At times we get some pseudo double bubble type. Here you can see that this is the stomach and this is a splenic cyst, which is to the left of the thing. Similarly, we can also get renal cyst, bowel duplication cyst, ovarian cyst, hepatic cyst, which may mimic like the pseudo double bubble, where the connection will not be there. Then how to differentiate the small bowel and the large bowel? So small bowel, as you know, it's slightly echogenic than the liver, and then it is usually in the central of the abdomen, while the large bowel is at the periphery of the abdomen. Small bowel seen in all the trimester, large bowel seen 23-24 weeks onwards, but definitely after 28 weeks. Anechoic fluid is seen in the small bowel after 16 weeks of gestation. Peristalsis is there in the small bowel, but no haustral pattern is there, while large bowel has typically the hypoechoic meconium, and then there is no peristalsis in this hypoechoic meconium, and the haustral pattern is very, very clearly seen. Now, what are the cutoff to say that yes, this is dilatation or not? So for small bowel, it should be a length of 15 millimeters and a diameter of 7 millimeters. More than this, it will be definitely a dilatation of a small bowel. And for the large bowel, if the diameter is more than 23 millimeter, then we say that yes, it is dilatation. And with dilatation and obstruction, again, we have to look at the peristalsis, which can be a very vigorous to and fro peristalsis. And then we come to the last part of the GIT, that is the fetal anus. So our own Bhupati sir has described this sign called as the perimuscular anal complex, where at the level of the perineum we see this sign called as the donut sign or even the target sign, where the central echogenic part is the mucosa and this is the muscle layer, and each and every patient we need to, after 20, they say that this sign is seen after 16 weeks, but yes, after 18-20 weeks it becomes very obvious. In early third trimester it is very obvious also, and it can be seen in your transverse section, or it can be seen in the tangential section, where you can very well see this anal dip and again this target sign here. So here you can see that the PAMC is absent here, and there was an abdominal cyst. There were a lot of enteroliths here, you can see that. And then when the birth occurred, there was total analatresia, and the invertogram also shows the same thing. So with the help of this PAMC and this enteroliths, the diagnosis of this case was made. Then we come to the liver. We all know the liver is in the right upper abdomen. It is more prominent in the second half of the pregnancy. Size increases during the pregnancy. It should be of uniform echogenicity. Normally we say that the liver is in the in the right side, but in cases of heterotaxy, this is the case of right atrial isomerism, where you can see this is a large liver. The stomach is here in the central, and the aorta and IVC, which should be on either side of the midline spine, they are on the same side. So now when it comes to liver, what things we are going to see? Basically, we are going to see if there are any focal lesions in the liver. Commonest are the calcifications, and there are multiple reasons for that. We are not going in detail of that because this is a lecture on basic anatomy. And then we have to look for the hepatic enlargement, which is common in anemia, infections, and certain glycogen storage disorders. Now, how to measure liver? So liver can be measured in two ways. It can be measured in a coronal scan, or it can be measured in the serratal scan. So first, in the coronal plane, we have to identify the aorta, and then we have to move our transducer slightly anteriorly, and then we have to visualize whole of the liver here, from this whole of this diaphragm here, from this part of the diaphragm to the right lower end of the liver. Here is the measurement of the liver, and then various nomograms are available. Similarly, in your SACH plane, you have to identify the IVC, and again from the diaphragm to the lowermost part of this right lobe, this is the measurement of the liver. This is how we measure the liver. Then we come to the gallbladder. We know that it is a structure anterior to the liver at 45 degrees roughly. It has to be seen in around 50% fetuses by 30 weeks and nearly in all fetuses by 16 weeks. Problem comes in when we don't see the gallbladder. If we don't see, again we have to follow the same protocol that we have to call the patient again after 24 hours and look at it. And then other problem we see is of enlarged gallbladder. If we see a very enlarged gallbladder, then we have to evaluate the fetus in very detail. If it is an enlarged gallbladder and it's only an isolated enlarged gallbladder, then it is nothing to be worried. It is a normal thing. But yes, if it is associated with abnormality, then definitely we have to evaluate for the same. And in the third trimester, gallbladder sludge and stones, they are also very common. And which usually postnatally they disappear of their own and they cause no much problem in the fetus. And then also we have to look other cystic lesions in the right hypochondriac lesion like the choledochal cyst, bilobe gallbladder and the hepatic cyst also. Pancreas we normally don't visualize, but now recent studies are going on wherein GDM mother they have established a correlation between the glycemic index, glycemic control of the mother and the pancreatic size and the future problems which will be happening in the fetus. And again, spleen, coming to spleen, it is not included in our routine scans. Nomograms still are available for the spleen measurements from 18 to 40 weeks of gestation. Again, splenomegaly is common with fetal anemia and viral infections. And how to measure spleen? Again, we have to identify the diaphragm here like this, and from the apex of this diaphragm to the lowermost edge of this wall, we have to measure the spleen. This is how we measure the spleen. And then the anterior abdominal wall, that thing we have to not forget. My God. Okay. So in the anterior abdominal wall, we need not, we have to remember about the physiological gut herniation, which is visible from 9th week onwards till 12th weeks, and herniation should never be more than 7 weeks of gestation. And in every scan, we have to visualize the gallbladder. Kidneys, we can visualize kidneys in the first trimester where they look rounded and echogenic, while in the second trimester onwards, they become oval shaped, and in the third trimester, we can very well see the corticomedullary differentiation. Kidneys can be visualized in axial, coronal, as well as in the parasite plane, and in each plane we have to take specific things. There is no specific cutoff for RPD in the first trimester. Basically, if more than 1.5 millimeters is there, we mention that it is a prominent, while in second trimester we know that the cutoff is 4 millimeters. And then the urinary bladder, which is visualized from 8th-10th week onwards. It's an anechoic area. The longitudinal length should not be more than 7, and it should be measured craniocaudal. The thickness should not be more than 2 to 3 millimeters. We have to assess bladder in each and every patient, and we have to remember that urethra and the ureters will not be visualized unless they are deceased. Normal adrenals is not a part of this, but when you get ambiguous genitalia, we have to look for the adrenals also. In the first trimester, the adrenals look as hypoechoic triangular area, which are almost half the size of the kidneys. In the second trimester, again they are area with CM differentiation, and in the third trimester, typical spindle shape with the CM differentiation. Fetal genitalia under PCP and DT we are not supposed to look, but yes, if there is some problematic history, X-linked disorder, some familiar disorder like in posterior urethral valves or ovarian cyst is there, yes, we'll have to look for that. And in genitalia, basically till 12th week of gestation, we are not sure about it. In the first trimester, the phallus, it points towards caudal when it's a female and cranial when it's a male. And in the last trimester, the visualization of the hydrocele is very common. We did not mention that in your report. And also whenever we see ovarian cyst, we better mention it as a pelvic cyst so that we'll not fall in the trap of this PCP-NDT. And now we come to the vascular anatomy. The vascular anatomy in arteries, basically we have to see the umbilical arteries, single or two umbilical arteries. And the umbilical arteries basically are visualized in our axial section, which is the common section we take. And in this SAT section also, we need to evaluate the umbilical artery. In SAT section, what is the most important thing which we are going to evaluate is this angle, which is called as the umbilico-aortic angle, UMA angle, or a K angle as described by Dr. Kavita Aneja. And this angle should be always an acute angle. Whenever you see that this angle is not acute and it is an obtuse angle or it is a 90-degree angle, then yes, we have to suspect that yes, there is some cloacal pathology in such type of patients. So now you can see this case here. This was a big cystic lesion. What my anatomy tells that this is not a bladder, because bladder should have ended here. This cystic lesion is going down here till the perineum. And then when I put on my Doppler, you can see here that this K angle is very it is means nearly obtuse angle here. And then the ambiguous genitalia was very well seen, and though this pregnancy was terminated, so it was an ambiguous genitalia here. And then there was cloacal dysgenesis, persistent cloaca, which presented as a cystic mass with ambiguous genitalia. And then in the fetal abdominal vascular venous system, we have to evaluate the umbilical vein, the ductus venosus, the portal vein, the inferior vena cava, and the hepatic veins. And when we look at these veins, because this is a very new area, because lot of anomalies can be detected, lot of syndromes can be detected by these vascular abnormalities. So a normal anatomy we must understand, and in these normal anatomy we have to see that yes, all these vessels are present or not. We have to see if they are in a normal location, what is their origin, what is their course, are the tributaries okay, is there special relation okay, how is their anastomosis, multiple things we have to know. And also we need to do the spectral evaluation if we want to go in a detailed evaluation for coming to the diagnosis. Now this is our normal section, a few 2 to 3 slides only remaining. This is our normal section where we take our umbilical vessel, and this is the ductus venosus. We take the ductus waveform here. This umbilical vein, it connects with the left portal, and then it forms this ductus, and then the ductus take the blood flow to the IVC and then to the right atrium. So what happens at time, the umbilical vein does not go to this this part of this the inferior vena cava. It may directly get attached here, and when it's get directly attached here, it is an anomalous drainage here. It may get attached to the IVC directly with the presence of the ductus, or it may get directly attached to the IVC without the presence of this ductus, or the umbilical vein, instead of going in the aorta in IVC anywhere, it can go down and join the pelvic vessels. And in all of these things, anomalies, cardiac anomalies, aneuploidies become a very important component, and therefore we have to evaluate these fetuses very meticulously when we see the ductus venosus abnormality. And then we have to look at the course of the umbilical and the portal vessel. Normally, as I have told you, that this concavity, this umbilical, then the left portal, and this is the portal sinus, the concavity of this should face always opposite to the stomach. When it faces toward the stomach and the gallbladder is seen here, we call it as a persistent right umbilical vein. Isolated persistent right umbilical vein has no much significance, but yes, if it is associated with abnormalities, definitely we are going to be worried. One more thing about PRUV is that the flow in that, because of the shape, becomes sluggish, and these are very prone to the umbilical venous thrombosis, and that can be a cause of sudden IUDs also. Do we measure the umbilical veins? No, normally we don't measure the umbilical veins unless we see that they are very much cystic, and this thing which is very common with the umbilical vein varix. And when the vein is more than 9 millimeters or more than 50% of the left portal vein, then we say that it is a varix. So this is how is the normal anatomy. So the umbilical vein, when this is the portal vein, the umbilical vein doesn't have any branches. When it comes and joins this branch structure, then it is termed as the left portal vein. So the umbilical vein comes here, joins as the portal to the left portal vein, and from here the ductus venosus goes, it goes to the IVC here. The umbilical vein then turns like this to become the right umbilical vein. From here the main main portal vein comes, and this is called as the X. So these anatomy we need to be perfect with very meticulously, because abnormalities of these are very important pointers, because if the umbilical portal, if the portal system is not developed, then these fetuses will die in first few days of the life. and you have to be very particular about this. Visualization of this X in last trimester becomes very important. So this is how is the anatomy. This is the left portal vein. The portal sinus comes here. From here the main portal vein come, and this is the right and the left portal vein. So here in this case I'll show you that the umbilical vein here came directly from this area, and then instead of continuing as the left portal, it divided into right and the left part. And so here the portal system was not developed, and the baby died 2 to 3 days after the birth. So to take home, to conclude, I'll say that be thorough with the sectional and the systemic anatomy. Be aware of the anatomic variations, mainly of the dynamic organs. And yes, the new concept of this abdominal vascular anatomy, we should understand that, because these are very strong pointers to the fetal pathology, and therefore we have to include the vascular evaluation in all our routine abdominal scans. Thank you very much for your patient listening.
Thank you, ma'am, for such a crystal clear lecture on the most difficult topic for our residents. Now, I would like to request Dr. Prasanna Mishri-Kotkar sir to felicitate Satarkar ma'am.